Welcome everyone to today's episode of BioTherapy Live. In case you haven't noticed already, we're having a few technical difficulties, but that is not going to keep us from having the opportunity to hear from a special guest from the other side of the world, and that's Dr. Mustapha Yusuf, who's a lecturer and honorary consultant with the Department of Medical Microbiology and Parasitology in the College of Health Sciences, Bayero University, Kano, and the Department of Microbiology, Aminu Kano Teaching Hospital at Kano, Nigeria. His biography or biosketch includes the description of him as a young researcher with a medical background, a master's in science, as well as an MBBS and a PhD. He's got experience in academics, laboratory, and biotherapy. Currently, his research interest is in the area of biotherapy, such as Maggot Debridement therapy for the treatment of chronic wounds, particularly in patients with diabetic foot ulcers. He has demonstrated how the use of this therapy reduced the extended hospital stay and decreased the need for amputation in patients with non-healing wounds, which is noteworthy development for nurses, clinicians, and the healthcare system, as we all have come to realize. So without further delay, but with enthusiasm for such a large crowd with us today, understandably, to hear from Dr. Yusuf. Please, welcome.
Thank you very much, Dr. Ronald Sherman. Actually, it's my pleasure to be hosted by the father of modern Maggot therapy. I have read in the textbooks and in the different articles about your researches, and I'm really pleased to be hosted by you today. And I want to talk about Maggot debridement therapy. I think I should share my PowerPoint. Albert is helping me to share it. Okay, let me share my slide.
Would you like me to open up your slides on my end, Dr. Yusuf? I believe you have the capability to share your screen.
Yeah, like to, okay, so. Let me share my screen. Okay, thank you. I believe you can all see my screen now.
Yes.
Okay, I will be talking about Maggot debridement therapy under biotherapy, and actually the first experience from Nigeria, West Africa. The aim of this, because we have so much quite a number of patients who suffer from chronic wounds, and usually these chronic wounds, they don't respond to antibiotic therapy, and they need to be debrided for good penetration and for good healing process. So this is why we are introducing Maggot debridement therapy from Aminu Kano Teaching Hospital, and like I've been introduced by Dr. Ronald Sherman. My name is Mustapha Ahmed Yusuf from Department of Medical Microbiology and Parasitology, Faculty of Clinical Science, Bayero University, and Aminu Kano Teaching Hospital. My discussion will go through this outline. First, I will give a brief introduction, then history of Maggot debridement therapy, current status of Maggot debridement therapy, wounds that can benefit from Maggot debridement therapy, what is the mechanism of Maggot therapy, then the larval morphology, because we need to know. People will ask, what specifically do these maggots or the larvae, what do they look like? And then I'll talk about some few studies that have proven or that have shown the efficacy of this therapy, patient perception, conclusion, and then some selected references. So as a way of introduction, you can see that, excuse me, in spite of the significant technological advances that have been seen in wound care, okay, I'm sure you are. Okay, so in spite of the technological advances that have been made in surgery and wound care management, wound infection and associated complications remain a serious challenge in the health delivery system. You'll all believe with me. And chronic wounds remain a great source of stress to patients, nurses, clinicians, and the healthcare system worldwide. The increasing rates of antibiotic resistant strains of healthcare associated pathogens and the healthcare pathogens and the need for alternative non-surgical methods for wound debridement has led to the reintroduction or the resurfacing of maggot debridement therapy in recent times. So therefore, what is maggot therapy? Maggot therapy is an emerging procedure involving the application of sterile larvae. Commonly, we use Lucilia sericata, though we have other species that can be used for this method, like Lucilia coprina, like Crasomia albicef, and some other species. But specifically now, we use Lucilia sericata to initiate and affect debridement, disinfection, and promote wound healing in wounds that are refractory to antibiotic therapy. Like you can see from this is the life cycle of the blowfly, a species of the Lucilia sericata. You have the adult stage, which gets to eggs in 8 to 24 hours. Then you have the larva stage, which lasts for usually 4 to 7 days. Pupal stage. In the pupal stage, usually you have the first instar, second instar, the third instar, then you have the pre-pupa, and then the pupa stage. The pupa stage will eventually lead to the emergence of the adult stage. So as a way of history, like you can see during the Crimean War in 1853 and to 1856, Nicola Parogov, who was a Russian surgeon, used MDT in the battlefield, where the technique saved soldiers' lives. And John Hopkins, professor of orthopedics, William Bay, was the first who treated, studied, and published a sizable series of patients into whose wounds he applied maggots or larvae. He was quoted to have said, "During my service in the hospital in Danville, Virginia, I first used larvae to remove the decayed tissue in hospital gangrene, and with imminent satisfaction. In a single day, they will clean a wound much better than any agents we had at our command. I am sure I saved many lives by their use, escaped septicemia, and had rapid recoveries." So this was the professor of orthopedic, William S.B., who was quoted to have made this statement. Now, what is the current status of maggot debridement therapy? In January 2004, the United States Food and Drug Administration issued the 510 clearance, thereby allowing the production and distribution of medical maggot as a medical device. Similarly, in the same year, in 2004, the British National Health Service permitted its doctors to prescribe maggot debridement therapy. Today, many therapies in the United States, Asia, and in Europe are using maggot debridement therapy in wound care management. In Africa, very few centers have reported the use of this method, while in Nigeria, for the first time, we announced the successful application of this method on various types of wounds. We will see some publications or some manuscripts that we sent on this. And these are various wounds that can benefit from maggot debridement therapy: diabetics ulcer or diabetic foot ulcers, infected burns, though we've not tried it in this aspects in infected burns, but we have a paper which we published in a international conference where we actually applied maggot on infants, and then non-healing surgical wounds, necrotizing fasciitis. We have been seeing these cases of necrotizing fasciitis in this center, and we've treated quite a number of patients with necrotizing fasciitis. In fact, just recently, a patient with necrotizing fasciitis in the form of Fournier's gangrene, we used Maggot debridement therapy to clean the debrided wound in a necrotizing fasciitis involving the urogenital area, that's Fournier's gangrene. And just 2 days ago, this patient had skin grafts, so he's doing very well. I would send that later. And then we also have osteomyelitis. You can also use Maggot therapy to treat those with chronic osteomyelitis and even pressure sores. So this graph, like you can see, it depicts the normal wound healing process. Usually, normal wound healing process has some stages or phases. We have the inflammatory phase, the proliferative phase, and the remodeling phase. And this is in a normal circumstance or in a normal condition. It is anticipated that most wounds will go or will respect these phases of wound healing. But what happens in non-healing wounds? In non-healing wounds, you have the inflammatory phase. You have the inflammatory phase overlapping with the you have the inflammatory phase overlapping with usually the proliferative phase, and then you don't have the remodeling phase. So if you don't have the remodeling phase, this is why you see we are referring to it as wound stalls. So the wounds tend to become chronic. This is why it takes months. Some of these patients, they spend months on the hospital bed without healing. What is the mechanism of maggot debridement therapy? The mechanism of action of medicinal maggots involve wound debridement, disinfection and inhibition or eradication of biofilms, and stimulation of wound healing. Maggot feeds on the dead tissues, bacteria, exudates, and cellular debris, thus debriding and disinfecting the wound. Wound debridement decreases the bacterial load, thus together with 20-hydroxyectiastion, stimulates the production of growth factors and fibroblasts, which are usually required to promote wound healing. This hormone is very important. It plays a role in the developmental stage of this larvae for it to move from the first instar or from the egg stage to the first instar, second instar, and the subsequent developmental stages. Furthermore, there is proteolytic enzymes that is secreted, which include trypsin, leucine aminopeptidase, carboxypeptidase, and alkalines such as calcium, urea, and allantoin, and ammonium bicarbonate, which further inhibits the bacterial growth by changing the wound pH. So all these play significant role to help in promoting wound healing. Like you can see, this is an electron microscope showing the morphology of the larvae, and you can see the roughing age which they use mechanically during the debridement process. And you can see the thoracic segments, the abdominal segment, and the anal division. Now you can see also, this is what we call the pharyngeal hooks. The pharyngeal hooks, they actually use it also during the debridement process, and it helps to debride the slough or the necrotic tissues. This is another clear picture of the larval morphology. You can see the pharyngeal hooks, and then you can see the roughing edge, which they use during the debridement process. These are some studies which has been conducted. First, we have so many studies that have been conducted by the father of modern maggot therapy, who is currently the host, in person of Dr. Ronald Sherman. Is my pleasure. And in 2003, a study was performed, a cohort study of larval therapy for the treatment of pressure ulcers. This was compared to conventional therapy in 103 patients with 145 pressure ulcers. In less than 5 weeks, the ulcers treated by biosurgery or maggot debridement therapy were 80% debrided, and 52% of conventional treated wounds were not completely debrided in 5.5 weeks. Granulation tissue also grew significantly more rapid in wounds treated with maggot therapy compared to the conventional therapy. Also in 2005, Armstrong and colleagues also compared the efficacy of maggot debridement therapy in 60 non-ambulatory patients with diabetic foot and 30 patients receiving conventional therapy. The MDT group has significant faster healing time compared to the conventional therapy group. The mean healing time for the MDT was 18.5 weeks compared to the conventional, which was 22.4 weeks. And the rates of amputations were noticed to have significantly been higher in the conventional therapy group compared to those who actually had Maggot debridement therapy. And in fact, this is the same experience which we are having here in our center. We've seen quite a number of patients whom were initially booked for amputation. Later on, we will show a picture of a lady who only just 2 hours to the amputation time. And when we intervene using Maggot therapy, we were actually able to save her foot from major amputation to just minor amputation. You can see also the Maggot debridement therapy had more antibiotic-free days compared to the conventional therapy group. This is actually not surprising because, like we've mentioned in the mechanism of the action of this maggot, they actually feed on the debris, that's the debris and then the bacterial load. So once you have significant reduction from our experience, usually when patients are on parenteral medication, usually after Maggot debridement therapy, they are usually converted back to oral medication because of significant reduction in the bacterial load. In 2009, Don Ville and colleagues also in a randomized controlled trial conducted with 267 patients with at least one venous or one mixed and arterial ulcer with necrotic or slough tissue. In the MDT group, the median healing time was significantly lower than the conventional therapy group, and the MDT group had reduced debridement time with a hazard ratio of 2.31. So now people wonder and they will ask, what is the perception of patients? What do patients really perceive about Maggot debridement therapy? So in 2004, Kitty, while 2005, Steve Bode and colleagues, and in 2008, Speedbury all and colleagues reported a strong positive experience of odor reduction and exudates among patients, while others commended the high rates of wound healing in Maggot debridement therapy as they would recommend it to others. Makong in 2013 and Egon in 2014 reported high acceptability of MDT and speedy visible improvements during the course of therapy. And also from my experience so far, this is the same experience which we are having when we know the pungent odor which comes usually with diabetic foot ulcers. But when we start Maggot therapy, in few days, this odor is significantly reduced. And then you have, because of the improvements which patients see, they end up recommending Maggots. I've had patients told me that, oh, had we knew earlier, we would have started this Maggot debridement therapy early. So these are studies that have been reported, and we are also reporting just from our recent experience. So now let's talk about the experience of Maggot therapy from Aminu Kano Teaching Hospital. And at this point, I want to say we may have some pictures which may be very graphic, and then I say, okay, there's viewer discretion is also advised because we will show some wounds, and then we may see some larvae because we try to show before Maggot therapy, under Maggot therapy, and after Maggot therapy. So in this experience, written informed consent was obtained from those administered with Maggot debridement therapy at Aminu Kano Teaching Hospital, and first install larvae of Lucilia sericata obtained from an indigenous company or indigenous farm were applied using the free-range method under aseptic conditions. I think people will ask, some will say, if you apply the maggots, aren't the maggot going to go away? So I always tell people we have different methods which we can apply maggots. We have the free-range method, we have the containment method, and then the confinement method. In the containment methods, we use the biobags. And we only use that when we have cavities, when we have wounds which we feel they are close to maybe some major vessels. But in other wounds, maybe outside the body, we use free-range method, and we apply this free-range using what we call the cage method of Maggot debridement therapy. So we form this cage, and then we apply the maggot, we roof it, and then we allow them to stay for 24 to 72 hours. So from our experience so far, we've seen sizable number of patients who have had Maggot therapy more than 50% are patients with diabetic mellitus foot ulcer, and from the Wagner grades 3 to 4. So, and this is not surprising because Nigeria actually has the highest prevalence of diabetes mellitus in Africa. And like we know, the prevalence of diabetic foot ulcer among those with diabetes mellitus is very high. And we also know that about 60% of lower limb amputation has been attributed to diabetic mellitus foot ulcer. But we've been trying to see how we can reduce this rate of amputation. So you can also see 30% out of our study so far were patients with necrotizing fasciitis. Necrotizing fasciitis involving the lower limbs, and necrotizing fasciitis involving the urogenital area, like Fournier's gangrene. Also, we've had 10% of who came with the patients who came with necrotizing fasciitis of the lower limb. And this was before Maggot debridement application. We used sterile gauze to form the cage. So this is the cage which we were able to use the gauze to form of Maggot debridement therapy. After forming this cage, we were now able to use a mesh, and then we formed the roof, which we placed over after applying the maggots. And then we now use sterile gauze, and we apply this sterile gauze over the roof, because ideally this dressing, because of usually wounds which have gotten Maggot debridement therapy are highly exudative. So we change this gauze in every 4 to 8 hours. And then after this roof, then we use a crepe bandage to cover the wound. And you can see this allows the maggots to remain in situ for 48 to 72 hours. So this picture shows how we cover, how we form the cage dressing, and then we cover. So like you can see, this was a 40-year-old diabetic patient who presented to our facility with forefoot gangrene. This first picture was at presentation, and this was under Maggot debridement therapy. You can see after we've had some cycles, and then this shows after Maggot therapy, we're able to clean the wound, and this was what we got. This patient was actually booked for above knee amputation, which is a major amputation, but she ended up having just minor amputation. Yeah, like you can see, she lost just D3 to D5, the foot from D3 up to D5. But eventually, this patient was healed and she was discharged, and this patient was very happy. This is another patient whom when we saw with this post abdomen, and this patient was on admission and he has had some series of wound dressing. But when we came in, we did Maggot debridement therapy for a just very short course, precisely 24 hours. And what the surgeons wanted was to remove this slough, and then they wanted to do a secondary closure. But after Maggot debridement therapy for just 24 hours, we were able to take this wound from this state down to this state, like you can see. And eventually, this wound became very opposed to each other, because what we are noticing, wounds which have had Maggot therapy, they have increased angiogenesis. So this is another elderly patient, 65-year-old with diabetic foot ulcer, who also presented to our facility. This was before Maggot debridement therapy. This was under Maggot therapy, and this was the clean granulated tissue after Maggot debridement therapy. It is also noteworthy at this junction to mention that part of the advantages of Maggot therapy is that they allow the normal anatomical structures of the wound. Like you can see in this wound, you can see the tendons, they are being preserved. You don't get this type of preservation when you do surgical debridements. In surgical debridement, usually you lose most of these tendons, but these tendons, they are very important during reconstructions for the plastic surgeons. The plastic surgeons, they use these tendons during reconstruction. So Maggot debridement therapy, they only take away the necrotic tissue and they allow they only take away the necrotic tissue and they allow the granulated tissue to stay. This is also another 40-year-old patient who came, diabetic patients. This was before Maggot therapy, and you can see this is under Maggot therapy, and this was after Maggot therapy. We were able to take off the slough. This is another patient, a diabetic patient with pyomyositis at the back. This was at presentation, and this was under Maggot debridement therapy, and we were able to clean the wounds within 96 hours precisely. This was also another, you can see 4-foot gangrene, 58-year-old with 4-foot gangrene. And when this patient came, we were able to clean the wound using Maggot debridement therapy, and you can see clean granulated tissue. This also another patient who presented with grade 3 of the Wegener's classification. And this patient actually was waiting for plastic surgery to have skin grafts. Unfortunately for this patient, after Maggot therapy, we had just within 24 hours of Maggot therapy, you can see how we were able to clean the necrotic tissue up to this stage. So what happened eventually, this patient had dressings for a few days, and this wound, it became so opposed because of the increase in angiogenesis, increased blood supply, and this patient eventually was discharged home. These another diabetic patients. Mind you, as I said earlier, most of the patients we see, about more than 50% are patients with diabetic foot ulcer, and it's not surprising, but we are doing our best to see how we can give this patient hope. And you can see this was after some days on admission and after Maggot debridement therapy, and this was the picture we got recently. The wound is almost opposing. So this is a 65-year-old patient who presented with our facility with necrotizing fasciitis of the lower limb, like you can see. This was before Maggot debridement therapy, and this is after Maggot therapy. Also, you can appreciate the preserved anatomical structures. You can see all the tendons, they are inside, and then you can see the wound is very clean. So we were able to get, this patient was skin grafted immediately after the wound was clean. You can see the skin graft, and this is the picture which we got recently from the patient after the wound has completely healed. So you can see from this stage, and this patient actually spent a very few time in the hospital or on the hospital bed, which would have spent longer if not for this Maggot therapy. This is also another patient you can see with necrotizing fasciitis of the lower limb, and this was at presentation. And after some cycles of Maggot debridement therapy, 120 hours precisely, 2 cycles, and we were able to clean this wound up to this stage. You can see the increased angiogenesis I was talking about. The wound is looking very healthy, very clean. And this patient was skin grafted also, and you can see the wound completely healed after the skin graft. This is one of the patients with a post-traumatic surgical wound infection. And when I saw this patient already has had surgical debridement, but the wound was still looking like this. So with just 1 cycle of Maggot therapy, within 24 hours, we were able to clean the wound, and the wound got better. And later on, this patient also had skin grafts. This is the patient I talked about. This is diabetic foot ulcer complicated by gas gangrene. You can actually see the gas under the soft tissue highlighted with this arrow. You can see this is gas under the soft tissue. Usually, this is a case of an emergency, but this patient appeared to be stable after the diagnosis of gas gangrene was made. So barely 2 hours to the amputation time, we were called to give a last option, which was Maggot debridement therapy. And this patient responded, and she also escaped major amputation, and she only had minor amputation. We are yet to get the updated photo of this patient, I'm sure the wound must have completely healed now. This is also another patient with diabetic foot ulcer. We try to clean off, to take off the slough, and we're able to clean, and then we hand it over to the orthopedic and the plastic surgeon to continue the management. So this is also another 60-year-old patient living with diabetes mellitus with forefoot gangrene. You can see this was at presentation, and we were able to clean the wound. And this patient also had what we call the ray amputation. So this ray amputation, if you notice this D2, the second digit is gangrenous. So the orthopedic surgeons were able to give this patient a good cosmetic surgery, which not many will notice that she even had this ray amputation. Okay, so this is also another patient with necrotizing fasciitis and diabetic foot ulcer altogether. So this was at presentation before Maggot debridement therapy. We were able to clean the wound, and after cleaning the wound, this patient also had skin grafts, and this patient was skin grafted by the plastic surgeons. This also another patient with extensive necrotizing fasciitis and diabetic mellitus foot ulcer. And this patient also, you can see after Maggot debridement therapy, I think for this patient, at some point in time, I personally also gave up, and I personally canceled this patient to consent to the amputation by the orthopedic surgeons. But this patient actually denied, he refused to consent. And he was very lucky. The lower limb vessels, they were still very patent. So this patient continued. He had several cycles of Maggot debridement therapy, and we were able to clean the wound. And you can see this was after cleaning the wound. He also had skin grafts. I'm also yet to get an updated photo for this patient. I'm sure he's also doing very well. So this was a paper which I talked about, where we successfully application of Maggot debridement therapy on infants with infected wounds. Also, recently we submitted this paper also to the Journal of Wound Care, the role of medicinal graded maggots in facilitating healing of diabetic foot ulcers in Kano, northern Nigeria, which is a case series. And this was also another paper which we submitted that has been accepted and is awaiting publication. Okay. Hello. Okay, this is another paper, like I said, and then we've also presented on the environmental factors influencing the growth of Lucilia sericata larvae used for Maggot debridement therapy. And in conclusion, Maggot debridement therapy was effective in the debridement and significant disinfection of wounds involving different body parts, thus enhancing wound healing with a good prognosis. Hence, the application of Maggot debridement therapy is recommended for such wounds. Maggot MDT is a simple and cost-effective treatment method for chronic wounds in developing countries. Minimal institutions presently are using this method in West Africa. So we are doing this advocacy to create awareness. Further clinical trial studies are needed where more parameters on MDT can be assessed, especially in developing countries like Nigeria. These are some selected references which we have used. Thank you. And this is my professor in Tehran University of Medical Sciences when I was undergoing training in person of Dr. Akbagzadeh and many other professors. I really appreciate all their mentoring in putting me through. And some of them, I'm very sure they are listening. They are with us right now. And thank you very much for your audience. And with this, I come to the end of the presentation.
That was fantastic presentation and some phenomenal cases. I'm going to let you unshare the screen at this point so that we can take some questions from the audience. And you may need to assist with that, Albert.
Sure. Let's see. There we go.
We have a lot of people in the audience right now. I'm going to recommend probably the best way to address your questions will be to write them down in the chat box. That way, even if we don't get to the questions, we will be able to answer them afterwards. I'm not seeing any questions in the chat box just yet, but Albert will check periodically and will help sort through them as best as possible. Do you see any questions yet, Albert?
Not at the moment, no. I thought I saw someone raise their hand in participant box, but it disappeared, so I'm not sure who that was.
So we can do some hand raising, and Albert will call on you, or I will if I see it.
Oh, we do have one question in the chat from Ayodele. I'm sorry if I mispronounce your name. The question is, can any housefly larva be used in MDT?
Well, for at the moment, we don't have housefly. Housefly, that's Musca domestica, is not part of the recommended species that we use in maggot debridement therapy, because we need to know that maggot debridement therapy is what we call a controlled myiasis. We have myiasis where you may have maybe housefly or Musca domestica. They may cause what we call pathological myiasis or myiasis. But for maggot debridement therapy, so far we are using Lucilia sericata, and in some climes people have tried Califora vicina, but ultimately, majorly, people are using Lucilia sericata. So we cannot use housefly. Dr. Ayodele, thank you for the question.
Let me just mention that I agree totally with Dr. Yusuf. If you look at naturally occurring wound myiasis, Musca domestica, the housefly, is very, very uncommon. Generally, the blowflies are the ones that are attracted to those wounds. That said, interestingly, there is one publication I'm aware of from China where they actually used housefly and described some success, but it's not what we use in most of the world, nor what most entomologists would recommend.
Yes,
Albert,
and I think another reason may be, you know, like Lucilia sericata has so many promising characteristics. Usually, after the debridement process, they try to go away from the wounds. They don't burrow deeper into the wounds, and we may not be sure if housefly or the Musca domestica, if they may exhibit those characteristics.
yes, indeed. Not much is known about those particularities of the housefly or many other species. So from a practical clinical standpoint, it's best to stay with what the research has shown to be most effective and safe. Although it is nice from a research standpoint, from inquiry, to eventually start broadening our understanding of some of the other flies. I see a hand from Hamisu Umar. So why don't you go ahead and unmute yourself and share your question, and then Albert will go back to the chat and see if there's any more chat questions. Or if not, Albert will read a chat question.
Okay.
Okay, I don't see Hamisu's question in the chat box, but we do have a question from Abdul. The question is, are there any side effects that are associated with MDT?
Okay, thank you very much, Abdul. With MDT, well, the side effects that you may be associated with MDT are not uncommon with the side effects which we see with the normal surgical debridement. And some side effects are even milder in MDT. For instance, I want to start with some patients may experience they may experience maybe some discomfort or pain. And then this pain is usually being relieved with some analgesics, and as you analgesics specifically. And usually this pain is usually experienced when the maggot or when the larvae gets to, let's say, the second or third insta, because usually we use first insta. So when we apply the larvae at that stage, there's usually no pain. Patient doesn't feel any sensation, but usually when they are growing bigger, some patients may experience some of these side effects. That's one, this pain which we talked about. And then another side effect may be sometimes if you have, let's say, maybe some blood vessels around, you may see some bleeding. And this usually are taken care of when we stick strictly to the calculation which we use by using the 5 to 8 maggots per centimeter square of the wound. Usually, or if we notice those blood vessels are usually big, we are usually very careful. And sometimes we may use the other method of application, which is the biobags. We may use the containment methods. Thank you, Abdul.
We have another question from Dr. Nagoma. He is asking if there are any failed treatments that have been reported so far, and what are the possible reasons for why the treatment did not work?
Okay, so what had happened from our experience so far, like I said, we deal with people who come down with diabetic mellitus foot ulcer grade 3 to 4. So most of the patients we see, because it's a teaching hospital, they present late. So they come late, and even at this late presentation, you've seen the wounds which we showed. So we try to see how we can salvage those legs. So in some patients, like in elderly patients who usually come with diabetic mellitus foot ulcer grade 3 to 4, we may not be able, we may start maggot debridement therapy, but some may already have advancing, let's say, deep-seated pus, and eventually the orthopedic surgeons may have to cancel them for amputation. So the reason which we can explain for the late presentation or for the failure may be late presentation, which we are seeing with some of these patients. They come late, and if they are elderly, some having some comorbidities, so we don't take chances. We actually, because some they present elderly, you may have some patients who may already have maybe other end organ damage. So we try maggot debridement therapy, and if we see as if maybe it's not forthcoming, we usually recommend the orthopedic surgeon to intervene. So we are usually very cautious in what we do, and this is why we are working together with the plastic and the orthopedic surgeons to save these limbs. Thank you, Nagoma.
If I may, I would like to read one of the comments, which says, this is from Dr. Ogunkeyede. Forgive me if I've mispronounced your name. It says, it reads, sorry, I had an experience with 2 patients with good debridement from housefly larvae. I would say, firstly, please don't feel sorry. That is great that you had success for the patient, and it is great that you tried something new and learned, and it is great that you shared it with us so that we can also benefit from your experience. So any feelings of sorrow or whatever, not necessary. That's great news. When I look at things like that, I say, of course, do no harm to the patient above all else, as we have been taught, but ultimately the patient is the one who is at greatest risk. They're the big gambler, even more than we are. And it's their leg, their foot that risks amputation. As long as we are honest with our limitations, we tell them what we do know, what we don't know, and the risks, and they're willing to take those risks. By all means, anything we can or have to do to save their limb, to save their health, is generally appropriate and good. So thank you for trying that. A lot of people don't have the blowfly species that have a good track record available. And time is of the essence. And we have to sometimes try things that we have available to them. So anyway, thank you for sharing that experience with us.
Thank you very much, the father of modern maggot debridement therapy, Dr. Ronald Sherman. And I would like to acknowledge I've seen hands from one of my professor, and also from His Excellency, the Nigerian ambassador to Tanzania, in person of Ambassador Dr. Hamis Umar Takalma. Your Excellency, it's my pleasure. We thank you. We really appreciate that you find time to join us. And please, Albert, you can continue. I think they can unmute and ask or contribute to this presentation, please.
Sure. Dr. Hamisu, would you like to go first? I see that your audio is unmuted.
Yes. Thank you very much, Dr. Mustapha, for giving us this,
Your Excellency.
Giving us this breakthrough in a medical field, especially as far as wound therapy is concerned, or wound care. I really appreciate the contribution. My question is, did you have identify or recognize any significant differences between the identity of the bacteria that cause this wound infection, gram-positive or gram-negative bacteria, and also the differences in whether it is toxin-producing or non-toxin producing bacteria? Because you have, from the pictures, you have identified one patient with a case of gas gangrene. So did you identify any progress or the speed of recovery from your procedure? Thank you very much.
Thank you very much, Your Excellency. And honestly speaking, one of the paper which has been accepted, we did that microbiological analysis. We took the wound swab MCS, but we did not go deep into these characteristics which you have talked about. And I'm looking forward into allowing students to venture, or maybe how we can get some grants so that we can do some more detailed work into this, especially our diabetic people living with diabetic mellitus ulcer in our locality. We need to do an in-depth study to see all these characteristics that you have mentioned with the pathogens, with the bacteria specifically. But we've isolated so far Staph aureus to be the leading cause of the organism so far in these patients in our environment, followed by Pseudomonas species. We know usually patients with diabetic mellitus ulcer, they have what we call usually polymicrobial organisms involved, and they have polymicrobial resistance. So we would love to see people to come in, and then we conduct research and see, and then we report the findings. Thank you very much, Your Excellency.
Thank you.
I see that Dr. Cameron Akbarzadeh has his or her hand up. Would you like to unmute yourself, Dr. Akbarzadeh?
Hello, everybody. Can you hear my voice?
Yes, we can hear you, Prof.
Hello, Mustapha.
Yes, Prof.
And
Yes.
it's very nice to see Professor Sherman, and
Yes.
it's honorable for me use and congratulations to you to to launch the Maggot therapy in your country. And
yes, Prof.
as you know, you were in Iran and you saw some of our works. We did
Yes.
Maggot therapy from about 6 years ago, and I had some emails to Professor Sherman as well, and he shared the great experience with us. So about Musca domestica, we have some small works in Iran as well, and it works for Maggot therapy. But you know, Lucida sericata is well known everywhere around the world, and it is well accepted by all scientists. So about bacteria, you know, we had a paper, we published it in a journal of wound and ostomy. And you know, I recommend to be careful for the use of Maggot therapy in the wounds with Pseudomonas aeruginosa. I think it should be done jointly by antibiotic therapy as well at the same time with Maggot therapy. So thank you very much to invite me for this nice webinar, and say good luck to you, and thank you Professor Sherman and all colleagues in the university. Have a nice day.
Thank you very much. It is worth noting that Dr. Akbarzadeh, or Professor Akbarzadeh, is actually the one who actually introduced me to the concept of Maggot debridement therapy in Iran, and he is also the father of modern Maggot therapy in Iran. He actually started this process. I actually worked in his insectary, and he was the one who put me through all the process of Maggot debridement therapy. And actually, we've had several lectures on how to identify. In fact, there was a paper he published on different characteristics of Lucilia sericata, and how you can identify Lucilia sericata using different characteristics. Thank you very much, Dr. Akbarzadeh. I'm really proud of you. And actually, you can see what you actually taught me. I came down and I'm actually impacting on people, and it is actually beneficial. Thank you very much.
thank you very much for Mustapha. And let me thank Professor Christopher Szpila from Poland, because I learned identification of the flies, especially working on Lucilia sericata under his supervision in Poland. So thank you very much. I'm in the meeting and using the good experience which will present here.
Thank you.
Yes, thank you very much for joining us. It's great to get to see you finally, and quite a testament to you, Dr. Yusuf, for all of your friends in high places. Very impressive. It is 12 o'clock, and what I thought might be possible, if you are not running off to another activity or very tired and needing to get some sleep, it would be okay from our standpoint if we went on a few more minutes to address some other questions. Is that okay with you?
It's very okay, Prof. Yeah, it's very okay.
Albert?
Sure. We have a question from Abdul Karim Dahiru, who is wondering if there are any economic evaluation studies that show either the cost effectiveness, cost utility, or cost benefit of MDT.
Okay. Well, so far from the little experience, we've seen publications though that have attested to the cost efficiency or economical benefits of Maggot debridement therapy over conventional therapies, though we are yet to take a study particularly concerning that in this environment. But what we've seen so far from our little experience is that some of those wounds which we actually showed on the presentation today, we were told by the surgeons that some of those patients, they actually will spend like 3 months on the hospital bed before the wound will be clean, and it will be good granulated for skin grafts. But we were able to clean those wounds in less than 1 month. So you can see, if a patient was supposed to spend 3 months on the hospital bed and the patient is spending less than a month, and with Maggot debridement therapy, you can see, definitely you are cutting the cost. And another thing is that we have what we call serial debridement, which some of those patients usually undergo serial surgical debridements. And each time those patients were to be taken to the theater for those debridements, it's a huge cost. But for Maggot debridement therapy, is a bedside procedure which we apply at the bedside. So it also cuts the cost of the theater and also reduces the exposure to the anesthetic agents, especially for patients maybe with comorbidities. So these are some of the experiences we've had so far. And also we've seen patients come in. Some patients are even semi-conscious states when they come, because the diabetic foot ulcer is polymicrobial infection, and then you have high bacterial load. But those patients, when they come on admission, they are usually being started on, let's say, parenteral medications. But after some cycles of Maggot debridement therapy, you are able to convert those patients from parenteral medication to oral medication, which is cheaper than the parenteral medication. So with this few experience which we've had, we think Maggot debridement therapy is actually cutting the cost of chronic wound care. And I'm sure Professor Ronald Sherman also have some additions to make in this regard. Thank you, Dr. Abdul Karim.
Yeah, you know me too well. I always have a few additions to make. I would only add that our experience, and I think most people's experience, is the same as yours. You can see the benefits, including economic benefits, from the work we do with the maggots, but it's very difficult to quantify. How do you quantify the economic benefits of someone avoiding amputation? They can now work where they may have had to give up their primary job, or at least spend 3 months in rehab had they lost one or more limbs. How can you measure and quantify the cost savings of not doing surgery? It's a little bit difficult. There have been, but if you're interested in pursuing more about the economics, there are 3 papers worth reading that come immediately to mind. One is by Stephen Thomas. That is a theoretical calculation of probable expenses. It's not an actual data-driven or clinically driven study. It's a theoretical economic study. The study by Wayman et al., my goodness, that would be somewhere around 1998, 2000, 2002, somewhere around then. That's a nice, real clinical study that showed significant financial savings in a small but prospective study of maggot therapy for venous stasis ulcers. The largest clinical study would be by the Dumville group. I think SOARS is the first author on the economic publication, which did not show any significant economic savings. But you have to keep in mind that that particular study followed patients up until wound healing, beyond just maggot debridement, and wound healing was not found to be expedited in that particular study. And so it's not surprising that there was no significant cost savings from the maggot therapy, which in most patients was done, or average, was done only 2 weeks for the free range maggots. The average was 2 weeks treatment out of a total of, I think it was 27, 28 weeks, somewhere thereabouts. So again, there may be multiple factors for not seeing the economic differences, but we have to look at all the data. We have to look at all the publications, and that is also one of those that looks at that question.
Thank you, Prof.
Albert?
I have a question from Diana, who's wondering if, Dr. Yusuf, if you can explain or describe how MDT is used to treat osteomyelitis.
Well, though I have not had an experience on chronic osteomyelitis, but I think we had a patient with which we wanted to co-manage with a case of chronic osteomyelitis. But in that aspect, I think when we started the Maggot debridement therapy, and at some point in time, the surgeons were supposed to intervene because there was this deep-seated pus, there was fluid. They were actually supposed to have maybe removal of that fluid. Then we are supposed to work together with this team, maybe with the ID team, because people with this chronic osteomyelitis, apart from the Maggot debridement therapy, we may need also to work together with maybe antibiotic, to be able to heal that. But I think I would reserve this question for Professor Ronald Sherman to contribute on the use of this chronic osteomyelitis on Maggot debridement therapy.
The conventional thinking about maggot therapy for osteomyelitis is that the maggots do not do a very good job dissolving hard tissue. They really dissolve soft tissue, meaning muscle, subcutaneous tissue, and things like that. Not so much for the fascia or the bone. That said, maggot therapy really got its clinical start at the time of William Baer on the osteomyelitis patients. He was an orthopedic surgeon. He dealt mostly with children and used it extensively for tuberculosis osteomyelitis. The way he used it was to surgically remove or resect the dead infected bone. At that point, though, many patients would develop another infection or would have problems healing, or perhaps there would be some more infection left despite surgery. And so he started applying maggots to those wounds and found tremendous success with wound healing. So what has been my experience and our experience with osteomyelitis? I and others have treated patients with minimal osteomyelitis successfully. That may be, in some of those patients, it's limited to a osteitis, or a more superficial, let's say, osteomyelitis. But what we see is that the dead bone, little pieces called sequestrum, actually separate from the rest of the bone and fall out. And then the bone, once the infection is gone, the bone covers with granulation tissue, and it is impressive. There is very limited information about that, but there is a publication in Advances in Skin and Wound Care about 2008, I think, that addresses off-label and unusual applications of maggot therapy, and osteomyelitis is included there. So my recommendation, bottom line, is, being an infectious disease doc, if you can cut it out safely, that's the most effective way at removing the dead bone. If you can't cut it out, antibiotics are sometimes useful, but if there's no blood flow, systemic antibiotics are not going to reach the area. And maggot therapy is worth a try if you have a wound or a sinus tract that goes to the bone, so that the maggots can reach it. That may be helpful. I'm done.
Thank you, Prof.
Thank you, Dr. Sherman. I have a question from Muhammad Ali. This one is directed to Dr. Sherman. If you were to use an alternative fly species instead of the Lucilia serracata, which species would you use for MDT?
I would use a blowfly, a caliphorid, and I would use whatever is most commonly local. That would be my advice. Easy peasy. That way, your any escapees are not going to change the ecology of wherever you are, and it's are going to be the most easily obtained.
Thank you, Dr. Sherman. I have a question from Mrs. Okotete. Will the presence of maggots already in the wounds do the job?
Okay, thank you very much. You see, I always say this to people because people will ask me before maggot debridement therapy, they will see some maggots in wounds. And I try to explain to them that that's what we call myiasis. And those the myiasis, they are caused by, you could have the tumba flies, and then you could have other species that can cause myiasis, and they are not medicinal graded maggots. So you are not sure if they cannot cause infection. So it's not really advisable. It's good to use the medicinal graded maggot, which has been sterilized and deemed fit for medical use. But you can have, and for so many reasons, number one, you could have those, the maggots which you even see on some of those wounds may not even, the quantity, they may not even, it may be suboptimal, may not be enough to even think of doing the job. And then these maggots, they are not, they are infected maggots, which may not give you all the sterile procedure or the sterile process which we are talking about. So, but nevertheless, some people still witness maggots, because this was actually how it was discovered, maggot debridement therapy, by just observation that some wounds which were infected were actually leading by maggots. And then some of those patients who actually had this maggot were seen to be surviving. And this was how it came up to this stage of maggot debridement therapy. But actually, so many studies had to be conducted. In recent time, like Professor Ronald Sherman had to conduct so many studies to be able to convince the United States FDA to issue the 510 clearance, which we are now laying our backs on from those studies. So we need to use sterile purified maggots to do the job. Thank you.
Thank you, Dr. Yusuf. There are no more questions that I can find in the chat.
Well, I have loads of questions. This was absolutely fascinating. And I don't want to take everyone's time with my questions. Usually I ask my questions because there are no questions.
Actually, since for you in particular, okay, we are undergoing the certification process and all those things, I know definitely you may have your own questions that you want to also ask. But please, it's okay. I think we still have some time. I don't know.
Well, I can also ask the questions later, but maybe I'll throw out a few questions,
Okay, no
because and then I have lots of questions that nobody knows the answer to, but you may be able to find out those answers, and so I'd love to talk to you about that.
No
and
problem.
one has to do with a particular wound that has been troubling me ever since my my stay in Sierra Leone 40 years ago, and that's the Buruli ulcer. Do you have Buruli ulcers in Nigeria? Do you see that?
Buruli ulcer.
Mycobacterium ulcerans.
Yes, Mycobacterium ulcerans. I think we have Buruli ulcers. I think we have that. We have that ulcer, and though I'm not sure if I've seen any yet, if in the course of maggot debridement therapy.
I will talk to you some more about that, but for for those who are not familiar with it, this is a very, very difficult ulcer to treat. And as you know, surgery is often contraindicated because so many people do not clear the margins of where the infection is. So they end up with what looks like a clean wound, but then it continues to grow even bigger and bigger and bigger. And the infection does not, or at least decades ago, we were not very successful in treating it with antibiotics. I haven't looked at the current status of antibiotics, but I have wondered for quite some time whether the maggots could be useful for Buruli ulcers. You also mentioned burns, but it sounds like you haven't yet treated a lot of burns with maggot therapy. Is that correct?
Yes, is correct.
Burns, I also saw a lot of in Sierra Leone. Usually children, often because of the open fires and cooking and so on and so forth. Do you see a lot of burns there in general at your hospital?
Yes, we have. Yes, in fact in my hospital now we have a whole ward that has been created for just bones and plastic wards, and we see a lot of cases of burns. But we want to use Maggot debridement therapy in those burns that are infected, deep burns that are infected. And you see what we are doing, and I think in this few experience which I have had, Prof. Sherman, I think we will discuss later, like some of this application of Maggot debridement therapy. I am devising some ways which we could use them, and those ways could be like a form of modified method, even the cage dressing or the confinement dressing, because of experience with some patients. I think we have like, I told you about the case of the Fournier's gangrene patients, which I used maggots. Just he had the plastic skin graft just on Sunday. So what I was actually doing in this patient, because of the sensitive nature of the perineal area, so I was actually using this maggot in just 24 hours. In fact, less than 24 hours. So I was more or less using Maggot debridement therapy more or less daily for him. I was not allowing it to stay for 48 hours or 72 hours, just to also reduce the discomforts which the patients may feel, or even the pain. But in using this method, patient may have to undergo repeated cycles of MDT, but it is actually better because you apply the maggot at the first instar stage, and because they have so much necrotic tissue to eat, within 24 hours, they have emerged, they have grown from the first instar up to the second instar, which is okay to remove them. And then we apply another first instar again. So this was how I was able to use this to clean this necrotizing fasciitis in form of Fournier's gangrene in this patient. And so far he has had skin graft. He's doing very well. In fact, he's very happy. So the same thing with these bones, because you know the superficial nerves, due to the sensitivity, we may also apply maggot debridement therapy, but for a very short course, because these maggots, they have so many advantages. Apart from the proteolytic enzymes which they secrete, they also stimulate the growth factors. So this may actually help in the healing process of this wound. And from my little experience now, we've seen that this maggot debridement therapy wounds which we treated with maggot therapy, they usually had 100% graft take. What I mean by 100% graft take, once we do the skin graft, they take the graft 100%. And this is because of the increased angiogenesis which we see in the wounds. So we have a lot of cases of burns And for those cases that are infected, we are going to be using Maggot debridement therapy. And also, we will see how we will work to maybe search for those patients with the Borrelia ulcer. And because this is all about science and it's all about conducting studies to see if this actually works, and then we report the findings. Thank you, Prof.
Oh, that's excellent. I have, I will just ask one more question and then I'll end. And that comes from a question I was recently asked about my experience using maggot therapy for patients with sickle cell disease and ulcers, very, very painful ulcers. And I don't have any experience there. Do you have some experience?
Yes, and I'm happy that part of the participants here, we have the head of the hematology department of the Amina Kano Teaching Hospital in person of Dr. Amina Ahmed Yusuf. And I think we've been discussing on how we could recruit some of these sickle cell patients with this ulcer. And then we try. I actually had one patient and he had only one cycle, but he was living very far away. He comes from where we call Maiduguri. And after that first cycle, he actually did well. So, but I need to recruit more patients. I think we have patients, we have the hematology department. They see these sickle cell patients. I think we can work together and see how we can try Maggot debridement therapy. I am optimistic that it will work on those patients, because I've also had some patients with venous ulcers and they did well on Maggot debridement therapy.
I think it should work well. Hopefully healing will follow, but dealing with potential pain may require some special attention to the dressings and methods, just like you put special attention on your Fournier's gangrene patient and your future burn patients. And that's what I'm trying to do now with a physician who would like to try maggot therapy to save his patients' legs from her chronic ulcers in the face of sickle cell disease.
Yes, we'll try that, and because so far we have many case reports which we will write and then we will send them. We are trying Maggot debridement therapy on different wounds types. We've talked about the necrotizing fasciitis in the lower limbs majorly, and then we are moving to the urogenital area. We've tried it on Fournier's gangrene, and then we in the maxillofacial units of the teaching hospital, they spoke to me. We also have patients who come with necrotizing fasciitis of the upper limbs. So we also want to see how we will try, and then we will keep trying, and then we will report all the findings. And we've also had patients with venous ulcers. And then the next stage is people with sickle cell patients with the ulcer, because you can see they walk about with this ulcer for many, many years. They go about with it for many years. And then the main thing is, if we can get the wound clean, we may not even wait for it to heal. We may just do it together with the plastic surgeons. Once we get the wound clean, if it is fully granulated, then I think they can have maybe skin grafts.
Well, I think you've been going about it wisely, focusing on certain patients, certain groups, certain wound types, getting experience, getting people in your community, your medical community, comfortable, and then gradually expanding to tackle another problem, developing that before you move on or spread yourself too thin. So your approach sounds very wise. Your experience is sounds spectacular.
Thank you, Prof.
And unless there are any more questions in the chat box, oh, there's a hand raised. I see a hand raised, yes. Dr. Agu, is it?
Yes. Prof, I just wanted to comment on, because there was a question I'm a plastic surgeon.
Yeah.
I practiced in Bayelsa State for a very long time, then before relocating abroad. And I just wanted to comment on the Buruli ulcer you mentioned. The presenter said it doesn't have cases of, but in Bayelsa we had several cases of Buruli ulcer. Is one of the commonest ulcer that you have around that place because of the damp nature of environment. So we have quite a lot of Buruli ulcer. When I started work there, the ulcers were quite common. People didn't know what it was, but when we now investigated it with the German leprosy department in Nigeria, it was discovered that those cases were cases of Buruli ulcer. It's quite common in Bayelsa part of Nigeria. And what we never tried any Maggot, even as before I left the country last year. We never tried any Maggot treatment in that place. But what we're doing, like you rightly mentioned, Buruli ulcer is mycobacterium. It's not ordinary bacteria. It's a mycobacterium ulcerans. So it's not usually sensitive to the common antibiotics that we use. So we're liaising with the German leprosy department and also liaising with our pharmacist. We're giving a combination of anti-mycobacteria drugs, not the conventional antibiotics, anti-mycobacteria drugs.
Okay.
That was what we were using, and because these wounds are usually undermined, and you continue to treat them with antibiotics, do a culture, you don't get anything. But when you now culture especially from the age of the wound, if you take a biopsy of the age of the wound, you can now get the Mycobacterium ulcerans, which is acid fast bacilli. And then you now treat in conjunction with the recommendation of the pharmacist. And most of the time, you clean the wound. It takes time. You continue to dress daily, but you must do anti-drugs, not just ordinary drugs, not just antibiotics. So, and when you do that, you clean up the wound. Then eventually, when the wound cleans up, most of them are either skin grafted or we raise flaps to cover the wounds. So that was how we're treating Buruli ulcers in Bayelsa. Thank you.
Wow.
Thank you.
Thank you very much.
Thank you. Well, I wish you the greatest success with those wounds. We had a terrible time with them when I was needing to treat those wounds. And yeah, but if you ever have trouble, a recalcitrant wound, and wish to give the maggots a try, contact Dr. Yusuf or contact me, and we will do, I'm sure, speaking for Dr. Yusuf now here too, I'm sure we will do everything we can to assist with those problematic wounds.
Can send me your email. I would love to do that. Can I have your email?
Sure. My email address, I will tell you now, and I'll put it in the chat box. Maybe you can put it in the chat box for me, Albert.
Sure.
Is R Sherman, that's RSHERMAN at UCI.edu. And Albert will also put in my Better Foundation email, which is rSherman@bterfoundation.org.
Okay.
And
Thank you very much.
You're very welcome. Well, to you, Dr. Yusuf, and to all of our many esteemed guests, thank you so much for joining us and for making this really a fantastic and fun day. We will be back with another program next month. If you're not on our mailing list, definitely go to our webpage or email me, or go to our webpage and sign up for our newsletter. And we will be announcing always who's the guest or what is the topic for BioTherapy Live webinar for that month. And with that, take care, all of you. Good day, good night.
Thank you very much.
All right.
Yeah.